So my role at the cancer hospital, I work at the Huntsman Cancer Institute and hospital, which is part of the University of Utah. And I actually run the high-risk genetics clinic for patients with Pheochromocytoma. And that's sort of how I got involved in this. The story is convoluted, how a head and neck surgeon ended up running this high-risk clinic. And the reality is nobody else would do it. And so I did it, and I enjoyed it. It's been difficult in some ways, but I feel like we have a really robust program. I mean, all of our patients that have Theo and Para get involved in a registry. If I see them in the high-risk clinic, they get enrolled in some biobanking registries and things like that through the Total Cancer Care Consortium. And so it's a fairly robust program. We see a lot of patients actually, which I think people don't really understand. We try to make that clear, but probably haven't done a great job. To make a couple of comments about what I've heard throughout the conference, but also earlier. Number one, surgeons are way underrepresented in this field. You have another surgeon back in the corner here. I don't know what you do, but
I don't know.
But we have a lot to offer, different perspective on things. We're not the ones running, gels and all this other science stuff. I don't have a lab. I shouldn't be allowed anywhere near a lab. I was a kid that lit the desk on fire when I was doing my chemistry experiments in college. But we do have a lot to offer, and there's some things about surgical management that are super important in this field, and I don't think really get talked about enough. From a patient advocacy standpoint, I'm going to tell you this one thing, and I'm hoping that my colleague agrees with me. You got to know who your surgeon is. And I've seen tons of surgery done that's either unnecessary or not really understanding what the risks are. And people get hurt if you don't have some expertise in this area. And it's funny, every time I come to this thing, a surgeon gets up to talk, all the other doctors take off. I don't really know why that is, but that's the way it is. But they need to hear this too, is the people that you're working with, which is mostly either medical oncology or endocrinology or something, they need to know who your surgeon is too. So they need to know how they were trained, what expertise they have. Not all surgeons are created equal, and not all surgeons do the same thing. I basically, from a surgical perspective, I'm from the clavicle up. That's it. I don't operate in the belly. I don't operate in the chest. And so as a director of the program, though, where I manage patients that have disease elsewhere, I got to know who my surgeons are, and so I make sure I know who has the expertise in those areas, so the patients get to the people. I know the surgery is going to be done the right way. And I don't think it's something that's talked enough, often enough, and it's really going to come from you. Like, who's this surgeon? Like, how are they trained? Like, where do they do fellowship? What type of surgeon are they? What things do they know how to do? Because surgeons, I'll tell you one thing about surgeons: we all lie. Okay? We always do way more cases than we actually did. It always takes us way less time than it actually takes us to do the case. It's just part of the deal. And no surgeon is going to say they can't do something, but being a surgeon that understands what your capabilities are and your limitations are is important. Okay. And in the head and neck, there's actually multiple surgeons that would be involved in care of head and neck tumor, and I'm going to show you why that is today. Stephanie. Hey, Stephanie.
Yeah.
It's not advancing.
It's not.
No.
Yeah. Okay.
I don't have anything to disclose. So I'm going to show you some figures. And all the figures and the images all come from this person, Rick Wiggins, who's our head and neck radiology university. He's the best head and neck radiologist I've ever worked with, hands down. And they have this really cool proprietary program where they have what I call cartoons. You got mad at me. But I'm hoping it'll be easier for you to see the anatomy with this, because the anatomy, especially at the skull base, is super complicated. It's really hard to see on an actual scan. So if this works, let me know, because then I'll try to do it again. But hopefully you'll be able to see some of the things involved with surgical management of head and neck tumors. So what are the tumors? So the crazy thing, and I'm glad if anybody saw the pathology talk yesterday, is really important, because these are all just paragangliomas, and what happened is historically they got named different things because different people described them and they weren't talking to each other, but they're all the same thing. And so you hear all this terminology, but it's all just paragangliomas, okay? So when we're talking about the head and neck, we're talking about glomus tympanicum. Those are specifically in the middle ear. So the middle ear is this aerated space behind your eardrum. It's where you get an ear infection, okay? And so you can have tumors in that location. What's more common is tumors in the jugular foramen, and that's where the jugular vein just comes out of the brain. So you have blood supply going into the brain, you have to have blood supply coming out of the brain, and the jugular vein is where that drains into. Anteriorly, or in the front, there is posterior drainage too, which we're not going to talk about, but that's the jugular foramen, okay? And there's other stuff in the jugular foramen, which I'll show you later, which is why some of this is important. Glomus vagal. So the vagus nerve also comes out of the jugular foramen, and there's ganglion tissue up high on the vagus nerve, and that's where we get the term glomus vagal. Okay, so and I'll show you examples of most of these. Glomus facialis. I've only seen one in my career. It's a super rare tumor. It's actually the facial nerve. Okay, and the facial nerve comes through the bone. If you tap on here, that's the mastoid. Facial nerve comes down through that bone to go out to move your face. And then carotid body tumors are also really common. Those are between the internal and external carotid artery. And those are the main ones that we see. I've seen them in a lot of locations in the head and the neck, and they're all associated with these paraganglial cells. All right. So just remember that if you can. Okay. So what makes head and neck paraganglioma special? First of all, they rarely secrete hormone. All right. I've seen 1 or 2 cases in my entire career of a head and neck secreting tumor. It's exceedingly uncommon. If you've been to some of the meeting, people have told you why that is, that we think. But for us, we just know they're not going to be secreting tumor. If you have a patient with a head and neck paraganglioma that has an elevated metnephrine, you better go look somewhere else, because it's probably coming from another tumor somewhere else. They're rarely associated with malignant behaving disease. Now, I know that some people believe, and this might be true, I don't really know, that all paragangliomas are actually malignancies with metastatic potential. That might be true. I don't think we really know, but they don't generally behave malignantly. And if they do, they're almost all of them in our data set are associated with an SDHB mutation. They can involve the base of the skull, and I'll describe what that is here in a second. They involve lower cranial nerves, which are special nerves, and we're going to talk about that here in a second. And in our data set, they're way more common than what I call subdiaphragmatic or abdominal paraganglioma. And I bet you that's true across the board. So they are a common location for paragangliomas to occur. So you need to be evaluated and managed by somebody who understands head and neck paragangliomas. All right, skull base. What is the skull base? You hear this term. You surgeons, I'm a skull base surgeon. Like, what the hell is the skull base? Does anybody have a guess about what that is? Nope. It's not this part. Okay, so your brain basically sits on a plate of bone. That's called the skull base, and it's got holes in it. Okay, and nerves and vessels come through the holes. All right. And when those tumors involve those holes, things get complicated because of the nerves and the vessels that come through the holes. So it's just a plate of bone. That's all it is with holes. And that's how I want you to remember it. It's basically right here. If you think about your brain, basically sits on a plate that's right here. Okay, that's the skull base. This is the cranium. This is the top part that covers the brain, but the brain actually sits on a plate of bone. It's like a table or a support for the brain. The spinal cord goes through the back hole, which is called the foramen magnum. That's in the back, and we don't have to deal with that, thank God, because that's high risk. And this is all what I call a high rank district up in this location. Lower cranial nerves are the name of the game. Okay, so what are cranial nerves? All right, cranial nerves are special nerves that come from the brain, not the spinal. Okay, so they actually come directly, the cell body for the cranial nerves is in the brain stem. And it goes, basically courses and goes through these holes in the skull base. And that's what we call a cranial nerve. And they're numbered 1 through 12, and they also have names. So us practitioners interchange this all the time, and I don't think patients really know what the hell we're talking about. So I'm going to try to explain it to you so you have a little bit better idea. So we only care about 5. All right. You don't have to think about the all 12. All you have to do is know 5. All right. First is the facial nerve, which is the 7th cranial nerve. Very simple. It moves the face. All right. So if you have a facial nerve injury, you don't move your face. Glossopharyngeal nerve is the 9th cranial nerve. It helps with swallowing. Okay. It elevates your palate so the food doesn't go through your nose. All right. The vagus nerve, really important, is the 10th cranial nerve. It does all kinds of stuff in the body. But in the head and neck, it's involved with voice because it brings a branch to the vocal cord. And it also helps with swallow. Okay, and I'm going to show you where that happens. The spinal accessory nerve is the 11th cranial nerve. It actually moves the trapezius muscle, the big flat muscle in your back. You know, you hear people call the trap, working on my traps. That's that nerve. Okay. And then the hypoglossal nerve is the 12th cranial nerve, and that moves your tongue. Okay. And all these nerves come through very similar locations in the skull base. So we're going to talk a little bit about carotid space paragangliomas. Now, what is the carotid space or the carotid sheath? All right. So the things that always exist in the carotid sheath are the internal jugular vein, the carotid artery, and the vagus nerve. Okay. So those 3 things are always in the carotid space. Up high here, here's the carotid, here's the vein, here's the vagus nerve. 9, 10, and 11 also course through the carotid space near the skull base. But they all go away lower down. So when you're dealing with a carotid body tumor, the only 2 nerves that you're going to deal with are the 12th cranial nerve, the hypoglossal nerve, the tongue nerve comes across the top of the tumor, and behind the tumor is going to be the vagus nerve. And you have to identify those, stay off of them when you're doing surgery. So tumors of the carotid space are carotid body tumors. Vagal nerve tumors are also tumors of the carotid space. Remember, the vagus is always in the carotid sheath, always in the carotid space. And they're below the skull base. They're not in the skull base like jugular tumors. So this is an example. This is these cartoons. I told Rick I wouldn't say that, but that's what it is. Of a carotid body tumor. And you can see the feature of a carotid body tumor is that it splays. The internal carotid artery goes in behind the tumor and the external goes in front of it. And it sits right in the middle there, and the jugular veins next door. And the vagus nerve is behind it. All right. And these are examples of carotid body tumors. This is a really good example where you can see the external carotid here and the internal carotid there. And it just kind of sits in the middle of those 2. This is called a lyre sign. A lyre is, you know, that shape. Okay. And carotid body tumors in general, I consider kind of freebies in the head and neck. You know, there's not a lot of bad stuff that can happen when you're taking out a carotid body tumor in general, especially when they're small. Not going to get into the vagus nerve. The big issue is if the carotid artery is involved, and then you have to sort of decide how you're going to manage that. In general, they can be resected relatively safely with less morbidity. there is a stroke risk when you're operating on any tumors in this area where you're manipulating the carotid artery. And that gives me pause, especially in older patients. And also embolization of tumors that we do sometimes before surgery has a stroke risk, and it's higher in older individuals. So I got a whole bunch of patients in their 60s and 70s that have carotid body tumors, and I'm not doing anything about because they're not changing. The stroke risk is just, in my opinion, something that you have to consider. Okay. So this is what they look like. These are hard to see on this, but there's a carotid body tumor, and the external carotid is there, and the internal carotid is right there. So splitting the carotids apart. In the posterior carotid sheath that I'm getting ready to show you, they push all the vessels forward because the vagus nerve's in the back, right? So all the vessels go forward. So that's how you tell the difference between the two. So vagus nerve tumors. So this is basically the carotid artery has been taken away. This is the vagus nerve coming down like that. And you can see it sends off these branches. So branches to the vocal cord. This is the superior branch of the superior laryngeal nerve. And that basically allows you to feel when you're swallowing. And then there's another branch. This is the external branch. I mean, this is the internal branch. This helps move the larynx to help you swallow. So if you have a tumor up here and you resect this tumor, none of these nerves below you work. And that's where the speech and the swallowing problems come in, because you basically knocked out your ability to move your vocal cord to protect your airway. And you've knocked out the ability for you to feel when you're swallowing. All right. And so that's where the complications of vagal nerve surgery come in. You can see vessels here are pushed forward, and the internal jugular vein is behind. Here the vessels are pushed forward, so that's internal and external carotid. And this is a vagal nerve tumor here. And so you can understand why we try not to operate on those, because of those injuries. This is the jugular foramen, where these jugular foramen tumors live. And what you're going to see here is this is the skull base, okay, the plate of bone. And you can see this is where nerves and vessels, this is the fifth nerve, go through these little holes in the skull base. This is the jugular foramen, kind of looking from the front. You can see the jugular vein, but you can see all these lower cranial nerves course through that opening in the jugular foramen. So tumors in this area, you knock out 9, 10, and 11 if you operate on these and you get into this area, okay? This is the 12th cranial nerve, comes out its own hole. But it can also, if this bone gets involved, you can also have involvement of the 12th cranial nerve. This is just a skull-based view, kind of showing you where these different paragangliomas are located in the lower cranial nerve involvement. This is an example, like I was saying, of a jugular foramen paraganglioma. Right in the jugular foramen, you can see how all these nerves are involved. And this is why you have to have an expert, a neuro-otologist, that knows how to manage this. And a lot of times we'll take out this portion of the tumor and radiate this portion of the tumor so we stay off the lower cranial nerves and improve functional outcomes. It destroys bone, okay? You see all this bone here is missing. Okay, and this is a good example of one that's stuck up in the jugular foramen. Getting there requires an expert, not you. Okay, it's a neuro-otologist. They're training in they do fellowship training in neuro-otology. They're ear doctors, and some of them are trained to manage tumors in the skull base like this. So, what are the treatment options? All right. Well, surgery is a treatment option. It's potentially curative. But you have to balance the morbidity with the complication. This is where the decision making in the head and neck gets really hard. Because I'm going to tell you, let's watch it. And you're like, what are you talking about? You know, like you don't want to take it. No, I don't take it out. Why not? Because you're not going to be able to move. Oh, okay. Well, what are we going to do? Well, we're going to watch it. Okay. So those are difficult conversations that require somebody probably like me to have with the patient. Radiation treatment is a good solution, better in older patients, because we don't know what happens 30 years down the road after somebody has radiation for a paraganglioma. And now if it grows and we have to deal with it, I'm in a radiated field operating, which is difficult. No, it's external beam radiation, just like you get breast cancer or anything. You say, I had radiation by breast cancer, that's external beam radiation. Potentially less morbid, but the tumor doesn't go away. And this is where some of the terminology that I hear in these rooms doesn't make sense. If you treat a tumor and it doesn't go away, you had a partial response to treatment. That's a real cancer medicine term. Okay. And in the literature, when they were like, well, they grew, they call them recurrences. That's not a recurrence. They never went away. You never had a complete response to therapy. That's progression of persistent disease, is how that would be labeled. And I've found in our community, we don't use these terms in a way that makes sense. And we should be talking about it like cancers, they're tumors. We use cancer terminology when we talk about tumors. And it's really unclear what the time frame is, like 15 years, maybe the longest study follow-up. And so we don't know what happens. So in younger patients, it gets really difficult to make a decision. I put observation in big bold letters because I believe that this is the first initial strategy for a head and neck tumor, is to just get another scan in 6 months and see how it's behaving before you jump in to a potentially inverted surgery.